So refresh your memory about cardiac circulation. There's one thing that I want to point out to you that you probably haven't considered before, but maybe you have. The oxygen content of blood coming back to the heart differs depending on the tissue that it's coming from. So as the blood comes back from the head, it has X amount of oxygen. And when it comes back from the lower extremities, it has a different amount of oxygen content. They mix together here in the right atrium and then in the right ventricle and in the pulmonary artery. And that's an important thing to understand. The oxygen content is different depending on what part of the body the oxygen or the blood is returning from. So keep that in mind. So after the blood goes to the pulmonary artery, it goes then to the pulmonary capillaries, and the capillaries then are up against the alveoli, and that alveolar unit that we've talked about is responsible for the gas exchange. Gas exchange happens. The blood then goes to the pulmonary veins and goes back to the left heart. Higher pressures on the left side, remember, and then the blood goes into the left atrium, through the mitral valve, into the left ventricle, and then out through the aortic valve and to the rest of the body. Now let's start with preload. So when you think preload, I want you to think about the stretch on the fibers of the left ventricle. Okay. We usually talk about left ventricular preload. So let's just think about the left ventricle here. When the ventricle is very full, it's stretching the fibers of the left ventricle. And when we stretch them to a certain point, we get really good stroke volume. The stroke volume being the amount of blood ejected from the heart with each heartbeat, right? So the more we stretch the fibers, as defined by the left ventricular end diastolic volume, the more we stretch those fibers, the greater the stroke volume will be. Until we get to a certain point where we stretch the fibers so much that they can't really function as well and the stroke volume falls off. That's the Frank-Starling curve. If you want a better explanation than that, you can watch this Khan Academy video. Just click on the link on your slide deck and you'll see a really good, albeit pretty in-depth explanation of the Frank-Starling curve and preload. Now, the other way you can think about this is to think about standing with your arm straight out and you're holding something heavy, like a book or something. If your arm is straight at 180 degrees and you have a really heavy book in your arm, you might have a lot of trouble bending that arm at the elbow in order to lift the book up. Well, why is that? It's because of the amount of stretch on the bicep. When your arm is fully extended, the bicep is fully stretched out and you can't lift really heavy weights. But if you bend your elbow even just a little, then you can lift a much greater weight. And that's because of this same kind of relationship. Now, it's not stroke volume and end diastolic volume, obviously, but when you have if your muscle's fully stretched out, it's not going to work as well as if it's a little bit shortened as it would be back here on the curve. Does that make sense? All right. So let's move on then. When we talk about preload, we don't just talk about one curve, but in fact, the heart muscle, as it changes function and goes to heart failure, has a flattening of this curve, right? So in a normal, young, healthy, hyperdynamic heart, this is what the Starling curve may look like. But as the heart disease worsens, we have a much different relationship between stroke volume and end diastolic volume. Okay? So the further we go from these hyperdynamic states up here to, a normal state to the beginning of heart failure and worsening heart failure, there's a very different relationship. So that as the end diastolic volume increases, even substantially, there is not much of a difference in the stroke volume. You see that? Whereas up here, we have a very big difference in the stroke volume with even a small change in the end diastolic volume. This is the healthy heart. Okay? So, reviewing, preload is the stretch on the myocardial fibers before systole, right, at end diastole. It essentially is volume status. When we talk about preload, we're talking about volume status. That's what's affected by it. And we talk about the end diastolic pressure, because that's what we can measure. It's hard to measure the volume, right? But pressure is close enough. And we're going to use that as our metric. Next is afterload. So afterload is the pressure that the heart has to overcome to eject blood, right? And you think about, what is the pressure if you're standing in the ventricle and you look up at the aortic valve and you're waiting for that valve to open? What pressure does the heart have to overcome to open that valve? Well, it has to open up, it has to overcome the diastolic blood pressure, doesn't it? Right? You think about that. The first pressure that's going to go and open up that valve is when it gets to the diastolic pressure, not the systolic pressure, but the diastolic pressure. Okay? If you want more of an explanation about that, click on this link. Again, a very good explanation from the Khan Academy people. So remember, afterload is the force needed to eject blood out of the ventricle, and essentially it's the diastolic blood pressure. You can just think of the diastolic blood pressure as being afterload. Okay? Then there's this thing called cardiac output. Well, cardiac output, I think you probably remember, is stroke volume times heart rate, right? Well, that's really what you need to know, but there is more to it than that, and we're going to talk about what else is involved in that. It involves the heart rate, yes, but it also involves preload. The preload helps determine the stroke volume, as we talked about. Then there's the contractility, or the force of contraction, that has to do with the stroke volume. And then finally, afterload has a big role to play as well. And we're going to talk about all these things in more detail as we go. So that's all well and good, but what does the stroke volume, the systemic vascular resistance, and all those other numbers I hear about, what do they mean? Well, here's the answer. So the stroke volume, as we talked about, is the amount of blood pumped by the left ventricle with each heartbeat. We talked about the cardiac output being the amount of blood delivered to the body, and that's expressed in liters per minute. Then there's this thing called the systemic vascular resistance. So if you remember any of your physics courses, then you'll recall that resistance is something that we have to take into account in any system, in any fluid system like this, or with electricity, for instance. And we express that in this really weird way called dyne seconds per centimeter to the fifth. It's very weird. And then there's also the pulmonary vascular resistance, which is expressed the same way, but that's for the resistance of flow through the pulmonary circulation. So this pulmonary artery catheter is kind of a cool thing. Balloon that inflates here with this little syringe that's attached to it. And so the red port is always the balloon port. And then there's a thermistor here. This is an electronic, it's just a wire that goes down the length so that we can measure the temperature at the beginning and the end of this little circuit that it does. And then we have a couple of ports that we can hook up and infuse drugs through or monitor pressures through. So what do we do with the pulmonary artery catheter? Well, one of the things we can do is we can measure the cardiac output. And this actually is, I copied and pasted this from Swan and Gantz's original paper I think it was in JAMA in 1971 or so, where this was the new method, this thermodilution method that they developed for determining cardiac output. Until then, they had injected green dye in. Cardiologists used this green dye to inject into the ventricle, and then they would see what it looked like in the pulmonary artery using some other technique that I don't understand. So the whole idea here is that we have a temperature monitor up here, and we know the temperature of the injectate, or the liquid that's being injected. Back when I started, we actually had iced saline that we would use, but now the technology's gotten better where they can determine the difference much easier with a more ambient temperature than ice water. And so they inject this known temperature substance into the proximal port, which is in the right atrium or somewhere in the central venous circulation. And then it mixes with the blood there, and by the time it gets out to the distal part of the catheter, where the temperature is again measured, then we can see how that cardiac output has allowed the temperature to change. Does that make sense? So again, we inject this injectate through here at a known temperature. It comes out in the right atrium. It mixes with the blood here, changes the temperature of this blood so that by the time it gets up here, we can know something about the cardiac output. So we're going to back up a step here, and we're going to talk about what happens when the catheter goes in. This is where you need your helmet. So put your helmet on so you can pay attention and not get hurt. All right. This is a little heady. So when the catheter goes in, the first place that we measure the pressure is in the right atrium, or somewhere in the central venous circulation, right? And when the catheter is in the right atrium, then we're going to see these things that are transmitted from the right atrium. We're going to see an A wave, maybe a C wave, and a V wave, all right? A and V waves are things that we see in the atrium, all right? And since the catheter is on the right side, we're looking at the right atrium. And that's how we know that we're in the right atrium. So we see a pressure of 0 to 8. We see A waves and V waves, if they're in sinus rhythm. And then we know that the catheter is in the right atrium. Then we inflate the balloon and it goes into the right ventricle. And here in the ventricle, the pressure is higher, right? It's say 25, 22, something like that. And the diastolic gets down to almost 0, maybe down to, somewhere between 0 and 8. And then the next cardiac cycle, it goes up again, right? That's with the catheter in the right ventricle. Now, the catheter goes into the pulmonary artery, and the systolic pressure is about the same as it was in the right ventricle, right? If there's no gradient there, if there's no pulmonic stenosis, then the pressure should be the same. And the diastolic pressure is different, though, because the pulmonic valve closes, and that leaves the pressure higher in diastole. And it turns out that pressure is somewhere in the neighborhood of 10 or so in normal people. Now, if we keep this balloon inflated and let it go all the way out until it wedges in the pulmonary circulation, now, the only pressure that's being seen at the tip of that catheter is this pressure. Look at this. There's an A wave and a V wave. But we're way far away from the right atrium now. In fact, that balloon is occluding the flow back here, so we can't even see what's going on there. So what do you think the pulmonary capillary wedge pressure really is? Well, it's really looking all the way through the pulmonary vasculature and seeing the left atrial pressures. That's what it is. So the pulmonary capillary wedge pressure is really the left atrial pressure. And that's a really cool thing if you think about it, but it gets even better than that. So notice that the pressures in the pulmonary artery in diastole are about 10. That's about the same as the normal pulmonary capillary wedge pressure. Well, the pulmonary capillary wedge pressure is equal to the left atrial pressure. See that? 10. And check this out. The left atrial pressure is about the same as the left ventricular end diastolic pressure. And that is what we really care about, right? Remember when we talked about preload? That's how we get the preload we put a swan in, we look at the pulmonary capillary wedge pressure, and we can see what the pressure is in the left ventricle at the end of diastole. That's really cool. That is very useful information because that tells us about a patient's volume status like nothing else can. Really good stuff. So always remember that the pulmonary artery diastolic pressure is about the same as the wedge pressure, which is about the same as the left atrial pressure, which is about the same as the left ventricular end diastolic pressure. So we can also get all sorts of other information from the pulmonary artery catheter. We don't measure anything else, but we can calculate things like the SVR. So the systemic vascular resistance is 80 times the mean arterial pressure minus the CVP divided by the cardiac output, and that gives you a really weird thing that we won't bother with. And by weird thing, I mean that weird dyne second per centimeters to the fifth thing. The next thing that we can get is the pulmonary vascular resistance. So remember, this is on the left side of the heart, and the pulmonary vascular resistance is on the right side of the heart. Okay. Darn it. And then there's the cardiac index. So I am 6'1" and rather sizable, right? And my 9-year-old is, 70 pounds. Not very tall. A cardiac output for him is dramatically different than the cardiac output for me. So how can we compare our hemodynamics? Well, the way we do it is with this thing called the cardiac index. So the cardiac index is corrected for body size because we take the cardiac output that we measure and divide it by body surface area. So I may have a cardiac output of, say 5 liters per minute. He probably only has a cardiac output of, 2 liters per minute, but our cardiac index should be about the same, right? We both have normal hearts. Hope so. So our cardiac index should be the same. So whenever we're talking about hemodynamics, we really want to know the cardiac index. It tells us far more information than the cardiac output does because the cardiac index is adjusted for body size. Okay. There's this thing called the left ventricular stroke work index. That's a very complicated thing that I don't want to bore you with, but I will tell you that it is essentially the same as the stroke volume. So when we get the LVSwi, the reason we look at that is because that tells us essentially what the stroke volume is, or what is the amount of blood ejected with each cardiac cycle. But that's not it. There's even more. So check this out. This critical care surgeon, physician guy came up with this great little story that explains everything perfectly. So I'm going to tell most of the story. I'm going to skip a couple of slides, but there was a pea monster, and this pea-eating monster lived near a pea factory, and a train delivered the peas to the monster all day and all night. And as long as the villagers delivered enough peas to the monster, he was happy and he didn't terrorize anybody. So the normal pea delivery consisted of 5 train trips between the pea factory and the monster every minute. Each train consisted of 5 cars, with each car holding 40 peas. So in 5 trips per minute with 5 cars per train, 40 peas per car, 200 peas per train, 1,000 peas per minute. All right. So the normal pea consumption of a normal happy monster was 10 peas from each car as it passed. So he consumed 10 peas per car, 50 peas per train, 5 trains per minute, 250 peas per minute, which came out to, you see what it came out to, 250 peas per minute that were consumed. But that meant that, there were peas that got returned as well. So there were 150 peas per train that were returned, and he ate 50 peas per train. That makes sense? So what does that mean? Well, It doesn't mean anything as long as everybody was happy and everything was working fine. But there could be problems. So if the pea monster got hungry and ate more peas, then fewer peas would be returned, and the factory might not be able to fully load the train cars before the train leaves the factory again, right? And as a result, there will be fewer peas to deliver to the monster during the next trip. The other potential problem is that the monster has short arms that limit how many peas he can reach. So as long as the thing is filled up, he can get the first 10 peas very easily. But the second 10 peas, he has to struggle a little bit to get to. And his arms are so short that for the next 20 peas, he just can't reach them, right? So that's a potential problem. Well, there's all sorts of other problems too. The monster could be overly hungry, or maybe there are too few cars, or maybe the train is too slow and therefore it doesn't deliver the right number of peas, or the cars are not full of peas because of some problem of production or whatever, or there's too few peas or the wrong peas, or the peas are there are peas missing in the cars, or the train loader of peas is broken and not working. Well, you can probably imagine that all of these things that we're talking about are parts of the cardiac output. So the hungry monster refers to increased consumption. So you can think of things that would increase myocardial oxygen consumption, or systemic oxygen consumption, and that could be fever and tachycardia and all that other stuff. Too few cars. Well, the cars that are carrying the peas are oxygen, right? But the thing that's carrying those peas is the hemoglobin molecule. So if the hemoglobin's low, then there's too few cars. If the cardiac output is low, then the train's too slow. If the oxygen saturation is low, then the cars are not full of peas. If there are too few peas, then the FiO2 is low. If the wrong peas are in there, then that's carboxyhemoglobin, right? Which is carbon monoxide poisoning. Make sure carboxyhemoglobin elevated. And then there can be a ventilation perfusion mismatch, which would be peas missing in the cars, or a shunt that can be responsible, or that we can describe as the train missing the loader. So I hope that's helpful to you in thinking about how the cardiac output works, because it was the same kind of story that was thought about by the guy who invented the other way of determining the cardiac output. So to talk about that thing called the Fick method, Dr. Fick's method for figuring out the cardiac output, we have to first talk about the P's, right? Well, the P's are oxygen. And remember that the body has two ways of carrying oxygen. One is it can be dissolved in solution in the blood, and that we measure as the PaO2, or the partial pressure of oxygen in the arteries. That's the little a. The other way that the body carries oxygen is when it's attached to the hemoglobin molecule. And remember, a hemoglobin molecule, normal hemoglobin molecule, can carry 4 oxygens, and we measure that with the pulse ox, right? The saturation of oxygen is the amount of oxygen that's attached to the hemoglobin molecule. So Dr. Fick came up with this very fancy way of calculating the cardiac output. It's a little involved, but essentially flow, that is cardiac output, so Q dot is flow, is equal to the VO2, that is the oxygen consumption of the body, divided by the oxygen content of arterial blood minus the oxygen content of venous blood times 10. All right. Now, to make it more complicated, I have to tell you that the oxygen consumption, the VO2, is the body surface area times 1.25. Fun, right? But the CaO2, that is the oxygen content of the arterial blood, is the hemoglobin times 13.4 times O2 sat in the artery divided by 100 plus the quantity PaO2 times 0.031. That's so complicated because we have to take into account the saturation and the PaO2, right? Then we have to do the same thing in the venous blood, calculate all that. This, by the way, this is a mistake I just noticed. Sorry, it should be O2V sat, not ASAT. O2V sat, because it's in the vein. And this is just way too much work, right? So let's skip it. Let's simplify this a little bit. Well, we don't need to do all that math, right? Let's simplify it and let's figure out how we can do the least amount of math and still get the numbers that are useful. Well, it turns out that the partial pressure of oxygen in the artery and the vein doesn't matter as much as the sats do. So we can get rid of all that other jazz and we can just do the SaO2, that is the arterial saturation of oxygen, minus the mixed venous O2 as the denominator against the BSA times 1.25 in the top part, all right, in the numerator. And that just happens to work out pretty well. Now, that's even too much work, though. We can actually make it even simpler. So we do this calculation, once a shift, maybe twice a shift if we need to, because it gives us, perfect information or near perfect information. We really like this. But what about this is really the only thing that's ever going to change. Is the body surface area going to change? No. Is the constant 1.25 going to change? No. Is the SaO2 even going to change? No. I mean, the patient's on 100% FiO2 or 60% FiO2 or whatever. It's going to stay the same pretty much. What's going to change is the mixed venous O2. And it changes based on the amount of oxygen that gets pulled off, right? The number of P's that the monster pulls off the train. So we can cheat. And we can ignore all this other stuff and we can just get right down to the basics and monitor the mixed venous O2. And we know that that's a decent estimate of cardiac output. So what happens is when the body delivers blood to the tissues, if the cardiac output is really low, then the blood is at the tissue level for a longer time and it can pull off more oxygen. So when the blood gets back to the heart, if the cardiac output is low, the oxygen content in the pulmonary artery is much lower, right? Contrast that with really high cardiac output, like we might see in septic shock or anemia or some other thing where the cardiac output is really high. Well, in that case, the oxygen gets sent to the tissues through the blood, but the blood is moving very quickly and the tissues don't have a lot of time to extract that oxygen. So when the oxygen or when that blood molecule gets back to the blood cell gets back to the pulmonary artery and is about to go to the lung to get reoxygenated, the oxygen level's higher. So remember that when the MVO2 or the mixed venous O2 is elevated, that indicates that there's a high cardiac output. And when the mixed venous O2 is low, that indicates that the cardiac output is low. Let me repeat it just one more time quickly so you can get that stuck in your brain. When the mixed venous O2 is high, that indicates a high cardiac output because the blood is going through the body more quickly and it has less time at the tissue level to exchange gases. So when it goes back to the train station to get refilled again, it already has more oxygen in it because it didn't have time to drop off all the oxygen at the tissues. Conversely, when the oxygen level, the mixed venous oxygen level is low, That's because the cardiac output is low. So the cardiac output is low. It takes longer for the blood to make the whole circuit around the body. And because it's low and slow, the tissue gets to pull more oxygen off of the molecules, off of the hemoglobin molecules. So when the blood gets back to the heart, there's less oxygen left because it spent more time at the tissue level because the cardiac output is low.